This conference will now be recorded.
Eye movements and visual processing are some other aspects. Eye movements can be child can use the eye, read the lens to and not. And then comes the visual processing. Under visual processing, whatever the child is being able to see.
Hello, Puneet sir. Excuse me. Your sound is not coming louder.
Hello. Is it fine now?
No, sir. It's also not audible with quality.
Okay, maybe wait
I
a
guess
second.
your headset. Yeah, now it's good. Now it's good, sir.
Yeah, okay.
Okay.
So shall I begin from the beginning or continue from here? Hello, Kapil.
Yes, sir. You can continue from here, sir. It was like just a few seconds.
Okay, thank you. So vision is much more than 20 by 20. The 2020 does not tell you if your child can see at near, which is critical to reading, writing, desk work, and computer work. A lot of our routine activity is only done whenever we see at near. And in a child, a near vision is very much important as much as a distance vision. Still, we forget to take near visual acuity. So we need to develop this habit that whenever any patient visits us, we need to take the distance visual acuity as well. The near visual acuity is the same important. Next, the 2020 does not tell you if your child can and his eyes can aim, move, and work as a coordinated team. Does the child's eyes working as a team or not? They are separated or they are producing binocular single vision. The 2020 can never tell you that. The child can easily pass out that test and maybe having this problem also. So has adequate eye movements to allow the eyes to rapidly and accurately shift along a printed page. Suppose a child is reading a line, a particular paragraph. So if his eyes are not moving quickly, rapidly, and accurately shifting, then he will be stammering. He won't read the letters as fine and as fluently as other child may be. So this all needs to be taken care by the parents, the teachers, and the optometrist. We need to administer the problem and then treat it by starting vision therapy, and can maintain clear vision at varying distances or rapidly adjust focus to copy from the board or watch the ball coming when getting ready to bat. Suppose a child is playing a cricket. So if the ball is coming, the player, the batsman needs to judge when the ball will arrive and how is going to hit it. So he has to shift the focus from distance to intermediate to near. It has to be quick and painless also. So if the child is having any issue with the accommodation, with the versions, he would be having headaches also associated with that, and the issue with the focusing on ball coming from distance to near. So each and every aspect of vision is different and cannot be administered just by a simple Snellen test. We need to test the quality of vision in the patients also. If the patient gets headaches from eye strain, the 2020 will never tell you that. If the patient has poor visual motor integration, that impacts printing or cursive writing. If the child has properly functioning visual memory and visual integration skills, whatever we see, we learn. Our mind comprehends that, and which contributes to visual memory. So visual memory is based on perceptual learning, and each and every child has some amount of visual memory associated, which when hindered, the visual system might be having some problems.
Puneet sir, are you there? Hello, Puneet sir, are you there? I guess we have problem with the network. Puneet sir, are you there? We are not able to hear your voice. Okay, let me check. Okay, let me wait for a few minutes. Okay. Till when he come back, we can play a small game or some interesting thing. So I have already mentioned you. Please, can you please inbox the which time is more favorable for you after the lockdown? Like in morning time, it will be a good, or after in afternoon or after evening, or in night, like 8 to 10 p.m. Which time will be more suitable for you? Can you please inbox me in chat box? I guess it will be more better for me in between the 8 or 10 p.m. Okay, this is the Topsum saying night. Okay, it's Topsum, when it will be good, like after the 8 p.m. or when you feel it's good, like it's night, right? But can you please tell me the which time is favorite food? Okay, 8 after,
Excuse me.
okay, yes, yes, please, you have any? Okay, no problem. Sandhya,
Yes,
after the post
no,
8 p.m., right? Thank
excuse me.
you. Any others, please, if you want to comment? Uh,
Kapil sir,
yes, Asmita, please proceed.
I think Puneet sir is continue with his
Yes,
slide.
I can
So
hear you,
can you
please.
please contact? Puneet sir, he is continue
Sorry,
with his presentation,
I can get you.
but we can't hear. No, Puneet sir, he
Okay,
is continue with his presentation.
yes, okay, let me check. Okay, let me check in WhatsApp,
So
okay?
can you,
I know it's not audible. Okay, let me check. Okay, let me check. Okay, I know he's continuing with the presentation, but Puneet sir, are you there, sir? Okay, now. Okay, I'm texting him and calling to me. He's not receiving the phone. Uh, hello, Puneet sir. Yes, sir. It was like you are proceeding with the presentation, but we can hear your sound. That's why I disturb you. You can't hear anything? Sorry, sir? Hello. Yes, sir. You can't hear anything or? Yes. No, sir. We can't hear anything. So I will just Okay, sir. Okay. Sir, okay. Okay. I guess we have to disconnect this WhatsApp first and have to connect, because if you're talking with me in WhatsApp and we, after entering the room, we can't hear you. Okay, let me check. My suggestion is plus Zoom use for the webinar. Dr. Yadindra sir, yes, we did try, but it's a very short period of time. They are only provide us 30 minutes of 30 minutes of time for meeting, and it was automatically crashed after the 31 minutes. So we used to conduct the webinar through the Zoom, but after having a lot of problem, we started from here. It was pretty much good, but I don't know what's happened today. Okay. If anybody want to put view on the vision therapy, they can proceed. If they have a different experience, or they can, everybody can share their ideas about the vision therapy. It's better than keeping silent.
Hello, Kapil.
Yes, yes, sir. Now we can hear you. Yes, sir. It's good.
Yeah, perfect. So I will just try it once. Please let me know. Tell me now.
Okay, sir.
Yes. Am I audible now?
Yes, yes, sir. You are. Yes.
Okay. So I will begin from here only.
Sir, I guess we are unable to. Sir, from the previous slide, can we go for the little bit ahead slide? Yes. Again, previous one.
Previous one. This
We
one.
miss a lot of things, I guess. No, sir. Again, yes, yes. Just wait. Just wait. I guess from the benefits of vision now, from if yes.
This one, right?
Yeah. Yes. Yeah.
Okay. So the question is, who can benefit from vision therapy? Well, earlier it was thought that only patients up till the age of 18 or 21 can benefit from vision therapy and can be treated. But a study was conducted in 1967 which proved that patients of all ages can benefit from vision therapy and will have the same effect that any child would have or any person under the age of 18 would have. Suppose you have a patient of 80 years and a patient of 8 years. The impact will be same on both and the result would be similar based on their other systemic conditions. So the age is no bar, age is no limit for treating any patient for vision therapy. Many patients which have been told it is too late or you have to live with it have benefited from vision therapy now. The nature of the therapy program varies with the condition treated. Suppose you have a patient of amblyopia and the another patient is of convergence insufficiency. So both of these are different patients and have to be treated with a different approach and different program. So it varies, the therapy varies with each and every condition, and any age can be treated seamlessly without any effort. We can treat a patient of any age. Now, what is the goal of vision therapy? This happy smiling man. A happy patient is the goal of vision therapy. When would the patient be happy? The patient will be happy whenever his symptoms are relieved. Suppose the patient was earlier complaining about vision or double vision, and whenever he can see a binocular single vision without any pain or without any much effort, without any headache, then the patient would be happy. And whenever he is happy, he will make your practice grow. And so a happy patient is the goal of vision therapy, patient free from symptoms and the vision system, the visual system working perfectly and producing a binocular single vision. That is the goal of vision therapy. Now, how long does vision therapy last? If the program is complete, the benefit of vision therapy will last for a lifetime. Suppose we have an amblyopic patient. The patient, after completing vision therapy, reached to 6 by 6. So Once he reaches there, he will stay on that visual acuity unless and until any other condition arrives. Suppose he had some trauma or something happened to the lens or cornea or any other pathology which may not be treated with vision therapy. Only then the vision would deteriorate, and if not, the benefit of vision therapy will last for a lifetime with the patient. There are no reversal chances. Next is accurate focusing and use of both eyes together efficiently is a reflex which when conditions should operate of effortlessly. The patient should not be making any effort or should not be facing any pain or any disorder in order to focus at something or in order to use both eyes simultaneously as a team. Next, self-monitoring activities are prescribed at the end of each therapy. Suppose before starting the therapy, we ask the patient to read a particular line. The patient can read.
Excuse me, Puneet sir. So your sound is so fluctuating. I guess it was sometimes louder and sometimes uh, difficult to hear you.
Even my internet connection is working fine.
Okay.
Can you ask the participants once if they can hear me?
Yes, yes. Okay, sir. Now it's good, sir. Now it's good.
Yeah, okay. So, shall I proceed now? Hello, Kapil.
Yes, sir. Yes, sir. Yes, it's good. Yes, sir.
Okay. So I will be proceeding now.
No, okay, sir.
So, okay. And non-medical vision therapy, as related to visual perception, prepares children for a lifelong learning and fills in gaps for many adults who have lost visual skills and abilities. So, to gain the skills, to gain the lifelong learning, we have to start with non-medical vision therapy. Non-medical, I'm saying, because we are not interfering with any other medical thing within the body. We are only and only improving visual skills and perceptions by starting vision therapy of that particular. So now what if I tell you our eyes function just like a camera? Just like a camera captures a picture and then it gets to a film and then we can see it. In the similar way, eyes captures the images. So in this case, as you can see, we are having two eyes. So suppose the person has went to see the Taj Mahal. So one eye has captured a clear view of Taj Mahal right in front of the eyes, and the second eye is capturing a kind of blurred vision of the same Taj Mahal. So what would happen in this case? The patient is getting the image from both the eyes, but one is clear and one is blurred. So both these images are not fused together. They won't fuse because they both are not the same. So until and unless they are same, they can't be fused. The visual cortex will deny to fuse it, and what would occur? The patient would complain you with the symptom of double vision and blurred vision at the same time. So this will occur as a double vision to the patient, and suppose the patient was an infant at that time. So with time, what would happen? The brain and the visual cortex will say, okay, let's just neglect this eye and focus on the clearer image we are getting. So in that case, it will occur as suppression. That eye will be suppressed on only the image from the better eye, the sound eye, will be taken by the brain, and the patient will say, okay, everything is looking fine, I am not facing any blurring issues. But until and unless an optometrist identifies it, an optometrist diagnoses it, the patient will live with the condition forever. So it is our duty to recognize each and every patient for his binocular symptoms. So Hippocrates once said, when the doctor sees nothing and the patient sees nothing, the diagnosis is amblyopia. So amblyopia remains as the diagnosis of exclusion up till now. That we perform all the other tests, then we conclude, okay, we didn't find this and no other issue with the fundus either. Then what is this? This is amblyopia. So what is amblyopia? Let's get to the definition. Some of you might say it is lazy eye, but that does not sum up the definition for this. So let's keep it aside and focus. A visual cacophony of deficits in
contrast sensitivity, spatial localization, fixation, ocular motility, temporal processing, accommodation, crowding, attention, motion perception, and visual acuity loss. And these all are to be hindered whenever there is an amblyopia. The quality of vision will be deficient rather than just when we focus on the visual acuity. We have to focus on overall quality of vision. We have to focus on the stereo acuity, on the visual acuity, accommodation and divergences, along with contrast also. So this was the definition given by Esperly in 2000. These are some of the other conditions that can be cured by vision therapy. First one is strabismus, squint. Then the next which comes is accommodation disorder, learning disability, as I was talking about the movie Tare Zameen Par, the patient was having dyslexia. Then convergence and divergence disorder, the patient is unable to focus at near or any far objects. So what was the solution to amblyopia? The earlier solution was patching of better eye. So what would occur? The first and foremost is cosmetic embarrassment. Suppose if you ask me to cover one eye and then go play with my friends or go to school or any other work, I won't, because I would face a lot of cosmetic embarrassment, and child face much more than a adult. So next, this is one of the biggest drawbacks of patching. The next one remains as difficulty in daily life tasks. So we have covered the sound eye, the better eye. Then we ask the patient to do the task. He won't be able, because he's already seeing blurred image from that eye. So he won't be able to do all of them easily. He would face all the difficulties. He won't be seeing TV that easily and that clearly, which would only cause headache to the patient. The third is extremely slow result. We prescribe patching to a child and then we say, okay, we have to follow you up after 6 months, after 1 year, then we will see what the result we can get. So suppose a child is following seamlessly without missing any chances the patching of better eye for 1 year. Then he comes to you and you see, okay, there are 2 lines improvement, you have to continue patching. So it comes up with an extremely slow result. The patient is not happy with that. Then the next one is risk of reversal. What is the risk of reversal? The sound eye, even the sound eye develops amblyopia when it is kept under patching for a longer period of time. So instead of the betterment of vision, we are just focusing on the fellow eye, and then we notice, okay, the sound eye is again gone now. So we have to shift to shifting patching of the eyes. Next is patient compliance is poor, as most of the modality of the amblyopic patient would be children. So children are not much compliant. Whenever you ask them to patch, they won't be very much easily available and very much easily willing to patching with you. Now, when we talk about prevalence of amblyopia, so as per research, 3 to 5% of global population suffers from amblyopia. Now, world population, when we consider that as 7.7 billion, the 4% of 7.7 billion is 308 million patients. So these much patients are present only and only with amblyopia I'm talking about. And if you consider with other conditions such as convergence insufficiency or other causes of asthenopia, a majority of chunk of your daily OPD would be asthenopic patient. I can guarantee you that around 70% of your daily OPD would come to you with a complaint of either headache or any other asthenopic complaint. Now, what is the army we are having? Only 5% of eye care practitioners provide vision therapy. There are only 5% of eye care practitioners who are aware with the vision therapy, and they provide vision therapy services to their patients. So we need to develop an army. We are in great scarcity if we talk about vision therapists. So we need to develop our specialty and we need to get into vision therapy so that we can treat this huge number of patients waiting for us. Coming to the classification of amblyopia, first and foremost, strabismic amblyopia. The strabismus, it is constant and non-alternating strabismus, which is the cause of amblyopia. Next, refractive amblyopia. Under refractive, first one is anisometropic refractive amblyopia, in which there will be a difference in the refractive error of both the eyes, right and left eye refractive errors. Then there's a meridional refractive amblyopia. What is it? Whenever there is an astigmatic component attached, which causes
amblyopia to the patient, which is high in number and causes amblyopia, it is meridian refractive amblyopia. Next one is isometropic amblyopia. In this, the refractive error is much larger and the same in both eye. Next is visual deprivation. Under visual deprivation, we have media opacities. Suppose the patient is having cataract or corneal scar, then the light rays are not reaching to the fundus. Then we have to treat that cause first, but it is causing amblyopia again. So it is media opacities, and the next one is ptosis. This is under visual deprivation. If there are ptosis, the patient might not be able to see clearly in case of severe ptosis. Then fusion. Under fusion amblyopia, as I was talking about, if you keep the sound eye under the patching, it will get reversal. So reverse occlusion amblyopia will be generated whenever you keep the sound eye under patching for a longer period of time. This was taken from American Academy of Optometry. Now, as we know that, okay, this is amblyopia, now we need to even categorize it. Which one is it? Is it mild, moderate, or severe? So I have separated that on the basis of visual acuity. According to Indian system, when we go with 6x6 thing, so it is 6/7.5 to 6/12. It will come under mild amblyopia. If it is 6/12 to 6/30, it will be moderate amblyopia, and 6/30 to 6/120, it will be severe amblyopia. This was taken from Padding in 2003. So this is the standards that we follow whenever we categorize amblyopia and whenever we need to grade that. So what is the management? What do we offer? So our goal is to restore binocularity and improve the vision of patient. Also, a happy patient is the goal of vision therapy, as we studied earlier.
Puneet sir? Okay. Yes, Puneet sir? I guess we have problem with audio. Let me check. Yes, we can hear him. We can hear you, sir. Yeah. Yes, at the moment we can hear you, sir. Can you please? Okay, we'll wait for a minute. Okay.
Hello, Kapil, am I audible now?
Yes, we even can't get audio. Manila ji, please wait for a minute. Yes, now, yes, sir.
Okay.
So can you please answer from the previous slide, sir?
This one?
Yes, we just missed. Yes, we just missed this slide. Yes, sir.
Okay.
Yep.
So the goal for the treatment is, first one is to restore the binocularity and improve vision. This should be our goal in any patient of binocular vision, that we need to restore its binocularity and we need to improve the vision of that particular patient. And then, as I already told you, a happy patient is the goal of vision therapy. So whenever the patient is happy, it will be a better thing for you and your practice. Next, Coming to the management part, we have to first establish optimal refractive correction. We have to give the best possible refractive correction to the patient in cases of amblyopia. Next, we need to improve monocular visual functioning of the child, of the patient. Next, that comes under is improve peripheral fusion first and then the foveal fusion. Then we need to obtain binocular vision in free space. Next one is we have to start a home therapy program which the patient can easily perform at home. So what does Curesi use? Curesi is a vision therapy software which can be accessed via desktop or a laptop on a Mac or Windows PC anywhere in the world, just like how we use Facebook. So it is available both online and offline. The patient can easily do it either it is urban condition or in a rural setup. So the patient can do this therapy exercise at their home, and all the controls of this will be to the practitioner only. The practitioner can sitting at their home, I can control the all the therapies of my patient sitting at my home only. So this is the convenience and the features of some vision therapy software. Next, what does this use actually? So first one is random dot stereogram RDS modules. Under RDS modules, what do I mean? Where you must have seen the Titmus fly test. It contains the small dots and then the butterfly appears 3D to you. In the similar way, there are smaller dots on the screen of the computer. The patient is doing therapy, and then the patient has to guess the box that appears 3D to him. Either it must be floating over the screen. A small 3D box would be floating over the screen. The patient has to tell us the direction of that box, and then he is using his vergences and stereo acuity to do so. And whenever he is doing it in different levels, we are improving his stereo acuity and his vergences, his ability to converge or diverge also. Next one is Diecoptics Principle. What is Diecoptics? So whenever we
Yeah, sir. Okay, let me check first who is icon on. Okay. I don't know. This name is yes. I don't know who is in.
Okay, so
sir.
the next
is
one
now
is,
it's muted. Okay. Yes, please.
so the next one is Diecoptics Principle. And Diecoptics Principle is nothing but the use of two separate colors to perform a therapy over the computer. How? Suppose we have, whenever we prescribe a therapy to the patient, we provide him with anaglyph glasses, as you can see on the screen. The glasses are in blue and red. So when the stimulus comes on the screen, it is again blue and red. Only the red and blue stimulus will come up on the screen. So what would happen? We are using only two colors of different wavelength and different spectrum. So it will be considered as Diecoptics principle. And once the blue eye sees the blue colors and the red eye sees the red colors, so monocular fixation in a binocular field. So this happens and the eye improves. Next one is anti-suppression technology. As the two colors are of different wavelength, it will be separated that only one eye will perform the exercise at a time. And then suppose once the stimulus is blue, so the right eye is getting the stimulus, then again the stimulus comes is red, then the left eye is getting the stimulus, just like how we do it in the gym, one by one the dumbbell with right hand, then the dumbbell with left hand, so that it will take rest and then improve, take rest and then improve. In the same way, next one is crowding phenomenon. As in the definition I told you, the crowding is also affected. So to improve that, what we do is we have managed many exercises and curated them. How? So that there will be many objects on the screen. The patient has to search and identify the particular ones. Suppose we ask him to search 2. There would be many 3, 4, 5, 6, many numbers on the screen, and the patient has to search for that particular number amongst all the objects, which will then improve the crowding also. Then the most important is we have individualized and customized contrast threshold. This was earlier not available at all. So what we did, we asked the patient to set his own contrast with their screen first. As the patient wears the anaglyph and then he performs the exercises. So during the performing the exercises, he sets his contrast first. So all the exercises would then be identified and customized or individualized based on the patient's contrast. So it will again improve the chances of patients getting treatment faster. as the therapy is much more individualized then. So now the question comes is why QRC? We have other softwares also, then why we should go for this one only? Well, the first and foremost, it's the only software in the world which runs both online, cloud-based and offline. Suppose if your patient is either rural or he can access to the internet. In both the condition, it is easily and very feasible to operate the vision therapy software. Then the next one is it is a comprehensive VT software. In this we have included diagnostic, evaluating as well as therapeutic modules along with patient record features. So you don't have to search through files as what I have prescribed to this patient. The EMR is also integrated within that software only. Within your dashboard, you can see what I have given to that particular patient. You can control that anytime. You can access the reports anytime. You can change any preference of any patient. Then the third and most important one is we have made it so affordable and efficient vision therapy so that practitioners can start easily. They don't have to invest much more just like they do in the previous time. So now it is the most affordable software in the world to start vision therapy. Next, it can be accessed both on Windows as well as Mac. And we are the only ones on the planet to provide patient support. Suppose you have a patient, you prescribe the software to him. Whenever he faces any technical difficulty, we provide a contact number for WhatsApp support, calling support, and email support to the patient. So it will save a lot of headache to the practitioner. The practitioner can have peace at the practice, and we would be handling all the patients in the technical efforts of the software. Now the next one is complete unlimited package. Earlier they used to charge it for sessions or for other some prepaid modalities, but we have did it as a postpaid. How? We provide a complete unlimited number of therapy session, unlimited number of times. How many times you want the patient to do, he can do it within 6 months. A complete unlimited 6-month package for each patient, including anaglyphs also. We are providing the anaglyphs at no additional cost, so you never have to worry and count for sessions. Next one is easy to use the interface. We have made it so easy so that anyone, any patient, either old age or a child, can easily use it and access it, just like how they play games earlier. And it is individualized and customized therapy for each patient. We use contrast, RDS, Diecoptics, MFBF all at once, so that effect will be much more and the treatment will be faster. Next one is live updated reports of each patient. Whatever the patient is performing, whatever the level he is reaching, how's the score, you can see the whole performance graph of each patient sitting at your home or from anywhere, anytime. You can see the real-time data of each patient's performance. Next is no hidden cost. QRC provides anaglyphs and flippers whenever required at no additional cost to the practitioner. We do not charge anything for anaglyph glasses. Now you all many of you will be wondering how to get started. So first of all, you have to register for QRC. Just go to www.qrc.com and register. Get zero cost training for binocular vision evaluation, workup, and QRC dispensing. Then you can easily start vision therapy at your practice. So this is the philosophy we believe in, that providing patient with overcorrection in spectacles is not the solution. We have to treat the cause of eye strain, headache by starting vision therapy for the betterment of patient and optimum results. This is how the dashboard looks to the patient. The patient gets this much number of exercises with many of them are monocular and many are binocular. So the patient can only see the exercises which are prescribed by the practitioner. Suppose there is a patient of convergence insufficiency and I prescribe him exercises for convergence. So if we give all and each and every exercise, he will mistakenly maybe sometime do divergence also. So what I have added is the feature that you can control, the practitioner can control which therapy or which exercise the patient can see. If I have selected convergence, the patient will see convergence only, no other exercises. So it is controlled by practitioner entirely.
Can you please mute yourself? I guess we have a problem with, I don't know, we didn't have problem, but Puneet sir had the problem. Waiting 1 second. Puneet sir, are you there, sir?
Yes, yes.
Yes, sir. I don't know, we just missed the last slide, sir. Demonstration 1 slide.
Which one? Just a second, wait.
Second last one, yes, sir. Okay. I don't know, you're again, you are disconnected. Okay. Yes, yes. Just
This one?
just before the slide. Okay. Yes, sir. Yes. While having the demonstration, we just disconnected. Yes, sir. Hello, Innova Technology. Can you please unmute yourself? I don't know who is that, sir. Even we can't hear you, sir. Puneet, sir, are you there, sir? Innova Technology. Can you please mute yourself? Puneet, sir, we are not able to hear you. Can you please rejoin it again, sir?
Hello.
Yes, sir. Yes, now we can hear you. Yes, sir.
Okay.
Okay, sir. Again, we missed the last two slides, sir.
Okay, shall I go through them once again?
Yes, sir, I guess.
Okay, okay, no issue. So you Hello, Kapil. Hello, Kapil. Hello. Hello.
Yes, sir.
Kapil, are you there?
Yes, sir. I'm here, sir. Now we can hear you. Yes.
Okay.
Can you please share your screen, sir?
Yeah. I'm doing that only.
Okay. I don't know what is the problem. We have to do.
I don't know. I've never faced this before.
Okay. Puneet, sir, can you hear us? I don't know. I'm not able to hear him. Hello, Puneet, sir. Are you there, sir? Hello, Puneet, sir. Are you there? Okay, I guess this slide had a problem with connecting the audio. Call 1 second to him, and we'll be discussing this slide by having. Hello, sir. Again, we have the problem to. Yes, sir. Again, we have the problem with to hear you. I guess by having the default of this program, we are not able to hear you. Can you please, sir, take a one screenshot and explain this slide, and we can go for the last slide.
If you can just post the screenshot in the chat box, and I would be explaining that.
Okay, sir. No issues. Okay.
So I'm just can you just take the screenshot? Let me know.
Okay.
I will end the screen sharing and start via audio.
Oh, okay, sir. Okay, no issue. Okay. Yes, sir. Yeah, you can proceed, sir. I'm sharing this screenshot.
You have posted the screenshot?
No, sir. It was just I'm just about to take a screenshot. It was a.
I thought you said you took a screenshot, then I just canceled it. So shall I go back
Okay.
there? Okay.
Yes, sir. Yes.
Oh.
Okay, I'm just taking it. Yes, sir. I take. Yes, sir. I took, sir. Yes. I'm going to share on chat box. Sir, can you please unmute yourself, sir?
Hello, Kapil.
Yes, sir. I share on our messenger group, but we didn't have any option to share on this chat box. So I guess
No issue.
yes.
No
By
issue. I
taking your
can.
screenshot, yours. Okay, no problem, sir.
Okay. So what you see on the above the image is that we are setting the contrast level for both red and blue color. So the all the colors and all the stimulus would be coming from red and blue stimulus only. So we are setting the contrast for that. How the patient has to select up to which level he is setting the contrast to the minimum level. The minimum level where he can just appreciate the color. Okay, like there's just a red circle is there, a blue circle is there. Only up till that the patient has to set to the minimum level of contrast of that eye. Then as he can select the exercise below, there are many exercises are there. The patient can select from there, and it asks him every time the time and the level for that particular session. So even the time and the levels are in control of practitioner. The practitioner sitting at home can control up to which level and up to which time the patient can perform the exercise in a single session. Suppose I have limited it to 5 minutes. I want my patient to perform the convergence exercise only for 5 minutes. Then it will only give him access till 5 minutes only. He cannot go any further than that. He cannot go any further if I select the levels of select 10 only. Then he cannot go beyond 10. He would be accessing up till 10 only. Yes, thank you for sharing. As you can see on the screen, above there's a option for setting the contrast, and in the below screenshot there's an option where it asks the time and levels always. So I guess I've summed it up. If anybody has any doubts, feel free to ask me in the chat box. I would like to answer that. And if somehow we fail with the time limit or anything, I'm posting my email in the chat box. You can access that or contact me anytime via that.
Okay, let me check. Is there any question or not? Okay, if anybody have the doubts or any queries, please come with the question. So can we? Yes, we saw the red circle and blue circle over there. So if we use the different color like green instead of blue color, is there any defect, sir?
Yes, we can use that, but there is a small difference that when we use red and green and compare it to red and blue, red and green has a shorter difference in wavelength of color compared to red and blue. Red and blue gives you a broad spectrum, so there are no chances of mixing in these two colors. So whenever the patient wears a red lens on the right eye and a blue lens on the left eye, the right eye can see red only and the left eye can see blue only. There won't be any chances that it will overlap. Just like you see during the Watford dot test, the patient can overlap that. But in red and blue, the patient cannot. The patient has to work in either in binocularity or monocular fixation in binocular field to attain. So red and blue provides you with
Okay.
a wider spectrum. That's why we use red and blue instead of red and green.
Okay. Sir, what is the difference? Like we have usually practice on vision therapy or vision therapy things with normal equipment, and what we are use in the orthoptic room or VT room. So what is the difference that we can if we use the secure instead of these goods?
Sorry, your voice was breaking. Can I please hear that once again?
Okay, sir. What is the difference that what we are using since for the vision therapy or orthoptic? Then, if we use the secure.
Okay. The difference is when in the traditional method of vision therapy, what we did is we either prescribed patching or we prescribed all the manual things that require either the patient to come up to your clinic and then you can perform that exercises, and in that also we are only stimulating systems one by one. We are not completing all the symptoms at once. How? Suppose if you prescribe patching, you are just only patching the sound eye. The results will be slower and all the other effects as I have shown you in the presentation. So the results as well as the effect, it has to be varied from whenever the patient performs a computer aided exercise. In the computer aided exercise, it gets all the different phenomena working together: the diecoptics, anti-suppression, crowding, contrast, visual acuity, and stereo acuity all works together to improve the visual system as a whole rather than just visual acuity. So the effect would be better and much longer sustained. Whenever you leave patching, there are chances of reversal, but after completing the vision therapy, there are no chances of reversal. This is the biggest advantage of starting vision therapy.
Okay, so there is one question from the also. Thank you so much also for your question. So can you please elaborate more about the therapeutic lens?
Okay, therapeutic lenses, like in the earlier times, what we used to do is we prescribed bifocal lenses to the patient so that whenever you see an amblyopic patient, the distance vision as well as the near vision is hindered. So during the therapeutic lenses, we used to provide bifocal lenses even to the children so that they can easily see the objects at near as well as distance. But that also has its own limitations. The patient starts developing issues in accommodation as well as emergencies. Up till then, whenever the patient wears glasses, it is fine. But whenever he does not use the glasses, the patient administers headaches or eye strain. So we have to rule out them. That is why nowadays nobody is focusing on bifocals, and rather than shifting towards vision therapy, because it provides a lifelong approach. The patient gets the treatment for lifelong rather than just shifting to glasses. Just like how earlier it was used to be myopia control, it you have to wear the spectacle only, but now we have a newer modalities also like ortho-K. So we have to shift towards newer modality. We have to shift towards what's new so that patients stays update and gets only what's advanced in eye care.
Okay, sir. So there is another question from the Manila. Thank you so much, Manila ji, for your question. So why we use only red colors in the right eye or green or blue color in left eye? Is there any logic, sir?
No, it is not standard. We also shift them during some patients. We shift that also. Why? Because there's nothing significant behind using red for the right and blue for the left. We just need to do that to perform diecoptics. Diecoptics is the use of two colors and to perform anti-suppression so that both colors would not get mixed. Both the two stimulus do not get mixed. So we can either use them in the right eye or we even provide reverse anaglyphs in that it is reversed. The blue is in the right eye and the red is in the left eye. So it has no other significant effect. It is just to administer the diecoptics as well as anti-suppression.
Okay, let me check. If anybody have doubts, please come with your microphone and we can also can talk in audio. So if anybody have doubt, please come and join for the question. So Samir, they're asking for difference between the orthoptic and vision therapy. In your perception, what is the difference between orthoptic? Yes, yes.
Orthoptics is the complete use of lenses and all other modalities to produce binocular single vision and to access and diagnose it, whereas vision therapy is the behavioral approach towards treating visual problems and conditions. It is the approach in treating, the approach for treating is called vision therapy, whereas for diagnosis and for the evaluation purposes, we call it either it gets often mixed with me or orthoptics.
Okay. Okay, if anybody have a question, please come up with the question. How is stereo acuity improved by the vision therapy?
Yes, as I earlier discussed, it contains modules based on random dot stereogram RDS, just like how we included that in the Titmus fly test. In the similar way, there will be modules coming up of the screen of patient. The patient is wearing anaglyph. Suppose you went to see any movie, any 3D movie. So during that, what you do, you see the movie in 3D, how you wear those glasses. Those glasses are also red and blue if you notice sometime. They provide you the effect of 3D. You see that in a stereo image, I would say. So it produces you the stereo perception. And in the similar way, what we provide is the anaglyphs as well as the RDS image, the random dot stereogram on the screen. The stereogram produces a box that appears 3D. It appears just like floating over the screen. So the patient has to tell us the direction where the box is floating. So whenever the patient, suppose he says it is floating on the left, the patient says left. So if it is correct, the computer administers it and proceeds to the next level. And if it is incorrect, the computer gets back to the previous level itself. It is called machine learning, and it is improved the stereo acuity. How? Just by using random dot stereogram. It presents with a 19 different level of stereo acuity. So some patient might be doing at 3 levels right now. Then over a course of time, over suppose 1 week, 2 week, they will progress to 5, level 6, level 7. So one by one, they step up, step up. How? By using the 3D goggles, what we call as anaglyph, as well as the 3D image, the RDS on the screen. So when these two combine together, it produces stereo acuity, and the stereo acuity improves after using it regularly for a period of time.
Okay, sir. Sir, there is one question. Let me check the question. Okay, sir. When patient doing the therapy, if patient wear red and blue glass all the time, like in your practice, he might be asking in your practice,
No.
patient should wear red and blue glass all the time.
So the patient does not have to wear them all the time. There are exercises which are stated as binocular. Under the binocular exercises, the patient wears this anaglyph, the red and blue glasses. But there are 5 exercises which are monocular. Under the monocular exercises, the patient does not have to wear those anaglyphs and will have to perform those exercises by occluding one eye just for a matter of 5 minutes or 10 minutes only. So that won't cause reversal, but the effect would be to the affected eye only. So that they are monocular exercises, and under the monocular exercises, the patient does not have to wear any anaglyph or any red and blue glasses.
Okay, so sir, Divya sir asking for Divya Joshi. She's asking for, can we give vision therapy in teenagers?
Yes, definitely. As I earlier stated, there is no age limit, there is no age bar, or there is no age limit where you should stop. Age is no limit. You can give vision therapy at any age. Suppose the patient is of 5 years or the patient is of 80 years. Both will have the same effect of vision therapy on them. It was stated in 1997. So we can start vision therapy in any of the patient of any age, being provided that the patient can comprehend whatever you are saying. It must not be an infant. If it is an infant, it would not comprehend what you are saying and it won't cooperate with you. So the patient should be just talking or comprehending your stuff, and then you can proceed either irrespective of the age of patient.
Okay, Divya, she might have got answer. Okay, so if anybody have the question, please come up with the question. Okay, if anybody have the please unmute yourself and proceed further question. If you have any problem, just about the end of the presentation. Okay, and considering the time limits here, I announce the yes, sir.
I'm extremely sorry for the inconvenience caused at the end. It was, I don't know, it was a technical fluctuation from network end only. So I hope I did justice to the topic, and thanks to the organizers and to the team of Mero Eye Foundation for this beautiful initiative, and especially to Kapilji.
Yes, sir. Thank you so much. We are also pleased and thankful for you. So before ending the session, I'd like to once again express my sincere gratitude towards the presenter, Mr. Optom Puneet, sir, and all the attendees. And also, I'd like to appreciate all the helping hands for the iTalks program. Herewith, I am ending the today's session, requesting all you please provide your review and feedback. Stay safe, keep inside, keep in touch. Thank you so much. Once again, thank you so much, Puneet, sir.
Thank you, Kapil. Thank you so much, and thanks to all the participants for joining us and skipping your nap time. I know how difficult it is to skip naps in the afternoon, but thank you all for your attention and just for you to bear with us during this time. Thank you, and thank you again, Kapil.
Okay, sir. So if you have any notes, good notes to make this platform more better, or if you want to give a note to us, like how to make this platform more engaging or more good in future. So if you have any good notes to us.
To me, it sounds completely perfect, and it is just perfectly organized by you. There might be some technical fluctuation. They are not in our hands to control, but definitely
Yes,
on the
sir.
next time we are coming up with a better version and better experience for every one of you. So thank you all, and thank you to Kapilji for today's session.
Okay, sir. Okay, sir. I will be keeping this for the few minutes. If any need to have a query, we can go for discussion. Although we have in the meeting, we'll wait for a few minutes and we'll disclose the meeting.